Today we will discuss about a diagnosis of psoriatic arthritis. Arthritis diagnostic algorithm. There is a musculoskeletal inflammation is present and joint pain, stiffness or swelling, tendon pain or swelling of example heel and plantar fascia, inflammatory back pain, psoriatic arthritis criteria are met in the presence of the active psoriasis and any one of the box designed with. According to the Grasper criteria, check for the nail psoriasis and presence of active psoriasis and a personal history of psoriasis, family history of psoriasis and a psoriatic arthritis. Helpful if there is no current psoriasis and dactylitis, sausage-shaped disease or toes. If it is not in the presence of the dactylitis, consider other etiologies like gout, sarcoid, sickle cell and infectious. Rheumatoid, check for rheumatoid factor. It is a negative, more towards the diagnosis of psoriatic arthritis. If it is a positive, assess the anti-CCP antibody and perform radiological evaluation for rheumatic arthritis and juxtaarticular bone proliferation and radiograph. Need to differentiate from the osteoarthritis and others. Each criterion met, probability of psoriatic arthritis is higher. This is the classification criteria for psoriatic arthritis, Casper criteria. In this psoriasis, mainly current history of psoriasis given 2 points and personal history, family history, first degree and second degree relatives, nail dystrophy, onycholysis, pitting, hyperkeratosis must be current, 1 point, negative rheumatoid factor, any method except latex, 1 point, dactylitis, current or historical if recorded by a rheumatologist, juxtaarticular new bone formation, ill-defined ossification near the joint margin excluding the osteophyte on plain hand or feet radiographs, given 1 point. Other differential diagnosis. Main differential for psoriatic arthritis is rheumatoid arthritis. Is usually positive for RA factor and anti-CCP and involvement of the proximal interphalangeal joint. Whereas in psoriasis, it is the involvement of the distal interphalangeal joint. And other one is a reactive arthritis. Is more likely to after GI and sexually transmitted infections, which are caused by Salmonella, Shigella, Yersinia, Campylobacter, Chlamydia. Gout is the most common. Gout is a more common in people with psoriasis than in a general population, likely due to the increased turnover and increased association with cardiovascular comorbidities and medications used to treat them. The most common DD may be osteoarthritis because of its high prevalence and the overlapping predilection for a similar patient population in terms of comorbidities. Osteoarthritis is usually less inflammatory than psoriatic arthritis, worsening with the activities at the end of the day and lacking psoriatic arthritis specific manifestations like dactylitis, enthesitis and spondylitis. In a subset of patients with erosive osteoarthritis, techniques such as the musculoskeletal ultrasonography and MRI may be useful to make the distinction. And in psoriatic arthritis, serology for rheumatoid factor is usually negative and inflammatory markers are normal. In rheumatoid arthritis, ESR and C-reactive protein are elevated. Treatment ladder. First line are NSAIDs, sulfasalazine, methotrexate, leflunomide. Second line include biologics, etanercept, adalimumab, infliximab. Third line include golimumab, certolizumab, ustekinumab. Coming to individual drugs, and methotrexate is used in both skin and psoriatic arthritis. Is more effective in both. Sulfasalazine effective in arthritis. Leflunomide is effective in both skin psoriasis and psoriatic arthritis. All the biologics are effective in both the psoriasis and psoriatic arthritis. Etanercept in effective in psoriasis, nail disease, and arthritis, and axial spondyloarthritis. And infliximab, etanercept, adalimumab, certolizumab, golimumab all are effective in skin psoriasis, nail psoriasis, arthritis, dactylitis, enthesitis, and axial psoriatic arthritis. And coming to adalimumab, it is effective in uveitis and IBD. And uveitis and IBD. Infliximab, uveitis and IBD. Certolizumab, effective in IBD, specifically Crohn's disease. And golimumab, effective in IBD, especially in ulcerative colitis. Apremilast is effective in skin psoriasis, nail psoriasis, and psoriatic arthritis, dactylitis, enthesitis. Ustekinumab, effective in skin, nail, arthritis, and dactylitis, enthesitis. And in inflammatory bowel disease, Crohn's disease. Tofacitinib, recently FDA approved, is effective in skin psoriasis, nail psoriasis, and psoriatic arthritis, dactylitis, enthesitis. And in IBD, ulcerative colitis. Abatacept is effective in especially arthritis. This is the management guidelines from Euler and Grappa. 2015 to 16 psoriatic arthritis guidelines set. Initially, conservative management, NSAIDs, physical therapy, corticosteroid injections, and topical treatment for psoriasis. And coming to first line, classical DMARDs. Classical DMARDs include methotrexate, and targeted synthetic DMARDs include apremilast and tofacitinib. Coming to Euler criteria, first initially treated with classic DMARDs, and then second line include TNF alpha inhibitors and classic DMARDs in combination. Coming to third line, switch to other TNF alpha inhibitors, interleukin 12 and 23 inhibitors, interleukin 17 inhibitors, and targeted specific synthetic DMARDs, which include apremilast and tofacitinib. Coming to Grappa, both classical DMARDs and targeted DMARDs are included in first line. And in second line, TNF alpha inhibitors, interleukin 12 and 23 inhibitors, interleukin 17 inhibitors, and targeted specific DMARDs in second line. And then third line includes the other TNF alpha inhibitors and interleukin 12 and 23 inhibitors, interleukin 17 inhibitors, and targeted specific DMARDs. Thank you.